Let's talk about people's processes and product. Again, I'd like to request Dr. Karunakar and Marikinti to share his presentation.
Last 30 years of working with countless embryologists and systems and various investments, economy, but the laboratory is no higher than the economy model, but it's presented as a premium model. But if you go to the details, you get to know. And then the other part of the world where the budget drives everything what we discussed today, nothing else, nothing but budget, nothing but the poverty or the richness of the thought process of the investor or the father figure at the lab dictates the investment and the maintenance and even the presentation of their data, which is usually biased. So I'm partly associated with the clinic, which is now 1,600 children are born in Middle East by Pankaj Srivatsal. So the Pankaj is always there in fertility field. So, and then the care and the bone hall, I'll go through. And then last 10 years, I've been traveling to different countries to contribute whichever way you can. And out of that, MSc embryology I had to do. So I'll just, in few slides, I'll just say as a clinician, how we use this. Couples2parents.com is a rich, free website to anyone who wants to card, and then there will be some embryology components to it. Whatever said and done, standing still is not an option for any civilization. You can't just say, this is what gave me good results and I'm going to stick to it. Or don't fix that is not broken. Certain things that you really, really got the best out of it, don't change it just because somebody else is doing it. Now, what is Compass? I don't know why who gave this title to me. It is just a device to indicate the direction. You may be dropping your pregnancy rates, you may be losing your business. The compass will not tell you. Compass is just a device to show which direction you are in compared to the north. That's all it will say. So we should not rely on that I'm advancing. No, you're going southbound also. What we mean by passing is that you have to direct yourself away from the cobwebs, the confusion on how much investment to put into the lab and how that investment will dictate the highest patient satisfaction rate. You don't have any other business. You should need to have this translational medicine. We all know in UK now, there's not much money left in NHS UK. What they want is all the scientists and technicians or technology experts, they want to convert whatever limited money they have to show a visible evidence in the health parameters, KPIs. So there's nothing, you can be a greatest researcher and scientist. So people should minimize unnecessary investment on certain equipment. That's what we mean. There's a lot of clutter in that. Then a basic IVF laboratory, yes, that's because of investment driven, but patient is not basic. The complexity of the sperm and egg and the air quality around which you are constructing your service will dictate the equipment and the investment that has to go in. You cannot have a fixed opinions. You need to be tailor making your investment, both in the equipment and the people and the processes according to the location where you are and the type of patients who are attending to your clinic. Otherwise, they will desert you. So it's only your success, your will be navigated by the quality investment that you do. Investment doesn't mean money. It includes money nevertheless. Then you move from a limited type of knowledge to an unlimited says. The science and technology, that's the way it's evolving. You can say non-invasive PGT, you can say anything. This is the circulation of an embryo, yolk sac circulation. I can show on 3D within 7 weeks of gestation. So that 3D machine works like an MRI. And very rarely I see a 3D is well utilized by clinicians to improve the hard-earned embryo given to us by a very, very sweating and very ethical embryologist. We are putting in a dustbin because you didn't assess the competency of uterus. Neither you gave good quality egg by working with the epigenetic injuries of a sperm and an egg. So before we use embryologist, after the embryologist gives the embryo, we have highest responsibility to value the work, the investment that is done to the laboratory and to the people that run the laboratory. So I have an immense respect for what I should give you and how I should respect what you give me back. Your role is in between. You are a fallopian tube, as far as I'm concerned. That's it. I need to work with the ovary and the testis first, get the uterus right so that the fallopian have, otherwise fallopian tube has no role. So whether it is structure of fallopian tube or the function of the fallopian tube, whatever media, whatever air quality you want to give, temperature quality, I need to give a better uterus and better egg and sperm to you in the first place. And then I need to use the better given embryo by you to put in a better uterus to nurture the pregnancy. So I just want to summarize, clinicians have the role of a uterus, ovary, and testis, and you have a role of fallopian tube. All of them work. All of them work. So that's how I use seized as a compass. Again, what cannot be measured is not a quality. Let anybody say, unless there is quality that can be measured by an inspection, we cannot assume anything. So that is need to be coming to effective. Whenever we are going to do it, they need to have knowledge. Some of the activities we are doing today, we are giving the knowledge of how to set up a quality lab. With touch-based knowledge of the human resources who will drive this. One is car, the other one is driver. Then they need to have training and experience, and the equipment is least invested. People are talking to me, I have this much money, I can invest a lab. I have seen people setting up labs with 35 Indian lakh rupees. There are assignments that is done. I have seen people investing up to 2 crores to invest in a lab. How do you judge them? You can always take in middle of the road approach. So we cannot really prescribe people. The quality will be outside the boundaries of knowledge, training and experience, and equipment. And of course, the attitude of the people who are investing in this entire project. If you think you're setting up a first-class service that includes lab, I don't want to isolate laboratory. I want to call it as a fertility center, if I may. So you need to be aiming 72% live birth rate with an investment of 1.4 to 1.8 embryo. That's that. Whether you got this 1.8 embryo with 1 batch of eggs, 2 batch of eggs. And again, blindly don't follow. Western world is great. This is Great Britain data I'm showing you. In a given year, 18.5% clinical pregnancy rate. In the same year, 52.1% pregnancy rate. So unless you audit, you're no wiser. You can have information about developed countries. You can have knowledge about developed countries. This is wisdom. Red profile couple, red profile patients, nobody can improve. A poor quality sum. So I want people who are listening here, if they're interested in setting up a high quality fertility service, this is 7 limbs of first class, healthy and successful ART business via auditable first class service by socially responsible healthcare provider. This is the boundaries in which we can set up. First, it always, the engine of this, any service is highest clinical pregnancy rate. The second, clinical and business efficiency. There are several parameters to it. The third, the clinical and business and resources risk management. These two contribute to audit. Audit means doing all the good things more and more, doing the bad things less and less. That balance is called audit. Then high team satisfaction. You all know, whosoever listening, people are jumping from clinic to clinic on the same hour, let alone in a year. So high team satisfaction, high retention rate will fetch you high patient satisfaction. High patient satisfaction will fetch you recurrence or patient retention rate. Without marketing, sales, and research and development, which we are discussing now, what are the new things? How do you embrace on them? Whether it is cost effective, whether there is any evidence driven, all that. And then the business development, that includes R&D. So quality is only that which can be measured. So for me, this includes everything what I want to say about contributing to set up a first-class fertility center. Anyone interested? We can discuss that another time. Whatever I'm saying is based on the first IVF center I was part of in Delhi Alani Institute, and then the Bone Hall Clinic, where the first IVF baby was created in this laboratory in the ground floor. What you're seeing is Bone Hall. This was my consultation room for 8 years. So whatever I'm going to share, it will be something that what these people taught me. And this has been my journey so far. Whatever I share, that. So as you know, Steptoe is here. This is the Bob Edwards team. Kay Elder, she was using the sports to teach ICSI in 2000 in Bone Hall, Cambridge. And the nurses who are trained there now have 4 fertility center in Australia. So what these people taught me is that you evolve. There is no fixed lab standards, equipment in a given moment of the time. And the more science evolves, more safety and more achievements that you get, you add on to it. You all know accidentally Palermo injected sperm inside Ulemma to call it ICSI instead of Susie, subzonal injection. So this is Simon Fischel. I worked 7 years with him in care fertility. So he thinks it's an art, as just an art, not ART. For him, art is an art. He's the one who's been using it. Now some company taken that name. So for me, I apply ABCD model. This is the clinician's direction to give credibility to embryologist and credibility to laboratory. If he stands out as a classic example that he is there to give highest pregnancy rate, which is 80 to 90 cumulative pregnancy rate, and he will prepare everything from his side, embryologist will be motivated to work with the clinician. The investor will be motivated to invest accordingly. So you need to, because it's investment driven, unless you assure the investor you are very high quality team and clinicians and you have some sort of data to support, the hesitancy comes. When there is a hesitant investment, quality compromises from day one. And that will perpetually compromising. And we all know that's what we want to avoid. So A being, how do you assess the competency of embryo, or how do you create a better embryo? How do you assess the competency of uterus and the living room or the food for the baby? If it is affected, how do you make it better? The C, how do you assess the interaction between the embryo and the endometrium or the guest and the host? If it is affected heavily or moderately or low or not affected, how do you validate that? If it is, how do you fix it? And where is the evidence for it? D is the general health of the couple. All of them together will give. I do universal assessment of all of them. It's called pre-treatment evaluation. Improving the quality of sperm before I even do the first IUI, improving the quality of the oocyte 3 months before I ever use the first oocyte, even for IUI, even for timed intercourse, even for ICSI or IVF or PGD, it doesn't matter. I work with the couple 3 months before, questionless, because the journey of an egg, the journey of the sperm dictates the journey of what you do in the laboratory. Unless I give a better prepared oocyte and a better prepared cytoplasmic and nuclear competency sperm and egg to you, I cannot expect much from you. Forget about the equipment, what you invest, and the air quality you have. They are secondary. The primary is that what quality gametes I'm handing over to my colleague embryologist. So my emphasis has always been this, and I work on it and I stand for it. Anyone interested, I can give as maximum evidence. Every single thing that I'm showing here is don't work on hysteroscopy. I was world's second largest data. This is the third child in Birmingham, UK. She was born. Now, I am aiming to run any consultation to give 90% success or 90% credible explanation why this man cannot become father with his testes or with his germ cells. My job is to give a child with 90% certainty or give a 90% accurate, peer-reviewable explanation why science cannot help this couple, a laboratory cannot help, an embryoscope cannot help, a greatest embryologist cannot help, greatest, ICSI cannot help. Nothing can help because we need to have scientific evidence where science ends. So my consultations are 90 minutes to 120 minutes before even I do first IUI. Trust me. I do free consultations last 5 years to any couple in the world. I make sure where they belong. So ABCD model I approach. I give them all the options, surgical, medical, combination. I will say who is suitable and what is per cycle, what is for 6 months, 6 cycles of IUI, and what does it take to get 90% chance of getting pregnant. And the reason I talk 90% is 98% of the children are born without seeing any embryologist, without seeing any gynecologist on planet Earth, even in the most industrialized world. So there is something good about the nature. We need to mimic the nature of fallopian tube to call it as a high-class lab. We know some and we are learning every day. So I give this data, which is green profile, amber profile, red profile. It applies to oocyte, it applies to sperm, it applies to embryo, it applies to uterus, it applies to myometrium, it applies to blood supply. And if it is red category, my cumulative pregnancy rate for that couple is invariably less than 10%. If it is green profile, my cumulative pregnancy rate for that couple, there is parameters, is 80 to 90%. 83, the most recent audited data, my own personal data. I have year on year from 2001. I can share the data with all of you. That is audited, peer-reviewed. So profiling, the stratifying the couple, not telling anything, telling what is the net per 100 couple walking into my clinic, how many actually will have a smile on their face, how many will have a frowning on their face. I take a written consent that what I said to them. So this is the 35-page document consultation I do. I take a consent before even do first IUI. And then there is an embryologist consultation I'll arrange. They will tell what they can do, what they cannot do, what the equipment that they don't have. Like, for example, they don't have sperm selection technique. They don't have PGT service. Whatever the evidence we have, but we are telling the limitations of particular resources in which. So the context where the couple are meeting you is explicitly shared with the couple so that if they can afford to go somewhere else, they can go. So transparency in information is my first consultation. I don't break this one. Everybody get to see the websites. What are the top 5 centers in each country? What makes them top? Or what quality egg and sperm gives them highest quality competent blastocyst? What is called top quality uterus? Why will they get 90% cumulants? What uterus will make 10% pregnancy rate? So these are explicitly shared after pre-treatment evaluation of the couple with due diligence. You all know the sperm analysis only gives 20 to 30% of the competency report of the sperm. DNA integrity gives another 20 to 30%. We don't know a lot more about the rest of the competency of the sperm. So we cannot say semen analysis is good. There is no male factor. I had the advantage to work even with polar body biopsy group of people. The largest we have is 124 polar body biopsies from Care Fertility, UK. So there are a couple who are coming. If the egg is abnormal, doctor, tell us beforehand that is the cause of abnormal embryo. We can choose a donor egg. If the sperm aneuploidy is dictating, sperm is consistently a contributing factor for a poor quality embryo, they're willing to go the alternate route. But without telling that, you do donor sperm, you do donor egg, it's heart-aching. I've seen this countless such example traveling across the globe for wrong treatments are offered for wrong reasons at the beginning of their fertility pathway. Everything, what else you have done, you must have invested $1 million in equipment and you're the greatest embryologist. But the person who is looking after them and the media they used and the monitoring they have done in their work, there are 7 slides which hurts me where this clinic was giving 18% live birth rate. 18% live birth rate is one of the well-known laboratories in the world. And this is 1-year audit. I'm just sharing, this is the most critical slide. You spoke all of that, how an embryologist alone can mess up the data. This is all audited. And how the clinician can mess up through his difficult embryo transfer, difficult endometrial assessment. How can he mess up success rate? Here we are talking about even 5% improvement. You want to invest on heavily costly embryoscopes. No, you have much more to improve. Obesity to improve, alcohol to improve, smoking to improve, all that. So I'm just saying the perspective, this presentation can be discussed. There is a erratic inputs of what happens in the fallopian tube substitute, I call laboratory and embryologist and andrologist and seminologist. They are contributing to a significant percentage of the bad name to the company and in our industry. That includes clinicians. They're also contributing. That's why I'm not isolating anyone. I'm telling how clinicians alone destroying your quality out parameters, how the embryologist, how the media, how the quality management system is destroying. So that's all I want to share for now.